Our next speaker is Dr. Savitri Sharma, and her title is Global Impact of Intracameral Antibiotics in the Prophylaxis of Post-Cataract Surgery Endophthalmitis.
Acute post-cataract surgery endophthalmitis is a rare but devastating condition, and the incidence varies from 0.06 to 0.36% in different reports. The vision that is achieved after treatment of such cases, according to EVS, bordered on around 1/3 of the patients getting not more than a counting finger or 20/40 vision. 20/40 vision, probably 50%, not more than 50% patients, and it remains almost the same now. Therefore, with the increase in cataract surgery volumes and worldwide rise in aging population, it is imperative that an effective postoperative endophthalmitis prophylaxis is available to us. We know that the incidence of post-cataract surgery endophthalmitis has reduced from 10% in 19th century to now probably just 0.01%, that is 1 per 10,000. This all has happened owing to the aseptic surgical protocols, perioperative povidone. We talked about povidone in greater detail, isolation of the eyelids, methods to do proper draping, and controversial, though controversial, used by many, the topical perioperative antibiotics. In addition to or in lieu of topical antibiotics, there is many reasons why we should be using or we can use intracameral antibiotic prophylaxis. There are many studies which have shown that at the time of surgery, there is an entry of periocular bacteria into the anterior chamber, more so when clear cornea surgeries are being done. It has also been shown that AC contamination is similar whether one is doing phacoemulsification or small incision cataract surgery. It is also known, and to the benefit of us all, that there is a persistence of high concentration of the drug if it is injected into the anterior chamber for several hours. These are some of the drugs which have been used for intracameral prophylaxis, more so vancomycin, cefuroxime, moxifloxacin, and lesser extent cefazolin and gatifloxacin. Now, we had a very powerful evidence in 2006, 2007, when ESCRS published this multicentric study and proved that cefuroxime is an effective drug, and this was the only RCT available to us. This study showed that there was a more than 5-fold reduction in endophthalmitis if the patients received cefuroxime at the time of cataract surgery. The drug is now available in Europe in the name of Aprocam and is widely used in Europe. Between the period of 2007 and 2014, very large number of publications came mostly from Europe, which corroborated the findings, and the drug became very, very popular, at least in Europe. Very few outside Europe studies were published, one from North Carolina in 2013 that showed the utility of not only cefuroxime but vancomycin as well as moxifloxacin. Our study, which was published in 2015, was the only one which did not show a significant difference after using cefuroxime. There was a reduction in endophthalmitis when the group of patients where we used the cefuroxime, but the difference was not statistically significant. It was also very heartening, Dane et al., when he published that there is a postoperative endophthalmitis in patients with the PCR can also be lowered with intracameral cefuroxime without the CME. Thus, David Chang was the one who wanted to know the situation in the USA. And in this country, a survey was held by ASCRS in 2007 and followed by 2014. And what he showed was that at least 72% of the surgeons were willing to use or were using intracameral prophylaxis during cataract surgery. But the drugs that were used, the top drug was, the most popular was vancomycin, followed by moxifloxacin and cefuroxime. So there was a variation in what people were using. But nearly 84% of them agreed that they would use intracameral antibiotic if commercial formulation was available. What were the concerns at that time, or in the US especially? Lack of commercially available drug and risk of errors in dilution was also a worry. There were reports of macular edema with high doses of cefuroxime. Risk of TAS, anaphylaxis cases were reported. However, the talk about whether antibiotic resistance would increase because of using this drug is unlikely. When Nasseri in his editorial wrote that if you give a bolus of the antibiotic at one time in the anterior chamber at the dose which is more than MIC is unlikely to cause resistance. Intracameral vancomycin was a choice of most of the American ophthalmologists. It covers mostly gram-positive bacteria. A report from Sydney actually showed very good results for over 15 years. However, the reports of hemorrhagic occlusive retinal vasculitis went for the downgrading of this particular antibiotic, and many of the surgeons actually refrained from using vancomycin. What about moxifloxacin? It is a very good antibiotic, fourth-generation fluoroquinolone. There are many advantages. It's a potent dose-dependent activity at low concentrations. Unpreserved drug is available, and Oromox, which is produced by Orolab, is available for direct usage of this particular antibiotic intracamerally. A landmark study from Aravind Eye Care System in India has published not only many papers which have shown the drop in endophthalmitis after intracameral moxifloxacin injection. The recent, not very recent, but 2017, they have published 1 million patients of different types of cataract surgery. They have shown a reduction in postoperative endophthalmitis by 3.5-fold. We tried to conduct a survey in India with the help of All India Ophthalmology Society, and we found that Indian surgeons, more than 40% were using intracameral prophylaxis, 46% were using only in high-risk patients. However, most were using moxifloxacin. Are there any concerns with moxifloxacin prophylaxis? There are publications about moxifloxacin resistance development. However, in this study, which we have reported 25 years trend of endophthalmitis and antibiotic susceptibility of 25 years, shows that there is the red arrow shows you that it's going down, and there is really no increase in resistance to moxifloxacin. Moreover, people have reported that high intracameral level from direct injection may be more than the MIC of the resistant organism in the anterior chamber, and there are reports of resistant gram-positive organisms eradicated by the intracameral moxifloxacin. The study from Aravind Eye Hospital has a subgroup analysis which showed that routine intracameral prophylaxis led to decrease in coagulase-negative staphylococci endophthalmitis. It is but logical that with the use of these two antibiotics by a large number of people worldwide, there is a comparison made between moxi and cefuroxime, and that study was done in L.V. Prasad Eye Institute, where I come from. The duration of the study was 18 months, and all patients who underwent SICS and phacoemulsification were included in the study. We have rural centers attached to our tertiary centers, and we had half of our rural centers, 7 centers, were asked to use cefuroxime, and 8 centers were asked to use moxifloxacin. And that's how we got to compare between these two drugs in very, very large population. The drugs were used in the usual concentrations that they're required to be used. And here is the result. We had cefuroxime 17,000 patients, and moxifloxacin was given in 24,000 patients. Both these groups had very, very significant decrease in endophthalmitis following the use of either of the antibiotics. but there was no difference between these two antibiotics. So we found both of them equivalent. In summary, there is mounting evidence that intracameral antibiotic is an efficacious method for endophthalmitis prophylaxis. In a Cochrane's review, the ESCRS RCT, that is only one available to us, was rated as conclusive and a successful study. Cefuroxime and moxifloxacin seem to be equally efficacious at this point of time, and it may help for FDA to give approval to these drugs for intracameral antibiotic prophylaxis. With this, I thank you for your attention.